Welcome to Share, a podcast production of Amethyst Recovery Centers. I'm your host, Kabir Singh. We like to remind our listeners at the top of each episode that addiction is treatable and recovery is possible. If you or a loved one needs help with addiction, call Amethyst today at 855-80-SOBER or visit us online at amethystrecoverycenters.com. It's been over a year since the COVID-19 pandemic drastically changed the way we go about our lives every day. Though many of us are physically distant, we still engage with others socially. Still, for many others, physical distancing has meant isolation. Our guest today is Dr. Rachel Wurzman. She is the Extra Care Program Manager and Director of Science at Seek Healing, a social wellness program that aims to rebuild communities in order to heal from loneliness, systemic shame, trauma, and addiction. Years before the pandemic, in October 2017, Dr. Wurzman gave a TED Talk called How Isolation Fuels Opioid Addiction. Today, we want to dig into her research, both before and after the pandemic. Dr. Wurzman, thank you so much for joining us today.
Hi, thank you. Thank you for having me.
So I was able to listen to your TED Talk. It was certainly very interesting. Predating the pandemic in 2017, a lot of what you talked about there is coming true today, but perhaps even more pronounced, magnified, whatever the word is for it that we find ourselves in the moment. I guess backing up, tell us, how did you get into researching, first of all, the opioid epidemic?
So originally, I wasn't researching the opioid epidemic, but I was researching systems in the brain that are involved in things like autism spectrum disorders. So you can see how that kind of relates to social interactions, but that's sort of where I started. And after I got my PhD, I was doing some research at the University of Pennsylvania, and a good friend of mine, Jennifer Nicolaisen, had started a community organization that was aimed at reducing opioid overdoses by providing what I had identified as just a very basic need, which was for people to have social support and be able to be integrated into social networks and infrastructures, not just in the capital R recovery community, but really just across the board. And she noticed with some friends of hers who were recovering from a bonding to opioids after going through treatments that had interrupted the withdrawal and the physical dependency, but noticing that there were all of these obstacles for people with significant trauma towards accessing other sort of recovery resources. And there was just sort of a basic level of what is life really worth? Where is there meaning in our lives? I mean, we can be abstinent from substances, but she really was looking at what is the quality of life that I'm living? And what she was identifying was that this disconnection between people seemed to be a really critical point. So she started coming up with this idea, and the model was really, really different back then. But she started talking to me about, okay, I've got this idea. We're going to have this program. It's going to do these things. And having done research at the National Institutes of Health and really kind of understanding these systems from an academic point, I started having input like, well, that's not really how addiction works. If you're going to be talking to these stakeholders, you really want to use this language, and like, well, that's, maybe that's a little naive, or that's not really how we think things are going on in there. And one thing kind of led to another, and I wound up being an advisor to the project and eventually becoming a board member on the board of directors to it. And I gave a talk at a fundraiser. And that talk was based on some social neuroscience work that I was doing from a completely different perspective. So I was looking at ways that our psychological health, kind of with the influences of social factors, biological factors, psychological factors, and the way that these really are complexly interacting. I had been doing research on interactions between social health and things like radicalization, which actually is a whole different tie to this year as well, right? So I had these systems, and it sort of came together. And so within the field, there are some really, really excellent social neuroscientists who have done some really amazing work showing that social pain, pain of isolation, pain of exclusion, um, the pain of not belonging actually activates some systems that are the same as physical pain.
If I may actually interject on that one particular, the adverse childhood experiences and what happens there, and they feeling not part of it. As a person in recovery, I often hear that that's sort of a predicating factor to, why I looked over here
Absolutely.
and decided to join the crowd that was, at that time smoking pot, right? And then it became this and it became that, and it got out of control.
Absolutely.
Are you finding that there is a factor that most often leads to isolation? Is it really anchored into the childhood experiences? Is it trauma based? Or
I think shame is actually the thing that links us all together. I mean, there's two different ideas that are really important here, and one of them is attachment, and the other one is shame. So the thing that trauma, any kind of trauma, does, but particularly early life trauma, and this can be trauma that happens. Dr. Gabor Mate talks about this, before you're even verbal. But what it does is it creates a sense of fundamentally not okayness. It creates it it creates conditions that make it harder to attach to others and have healthy relational interactions with other people. So shame really leads to isolation, and trauma really leads to shame. And it's sort of like a big spiral. So it doesn't actually have to be a big trauma in early childhood. Obviously, the ACEs are very well known as tied to addiction, tied to chronic health conditions, and really, I'd say deaths of despair in general, right? So that's going to include obesity, that's going to include suicide and other things like that.
Could you real quick, for the listeners that are listening, talk, you use the word ACEs, and I know what that is. Could you quickly just tell the listener
right.
what an
Sure.
ACE score is?
Absolutely, right. So you mentioned the adverse childhood experiences. So ACE, adverse childhood experiences scale. So there's a scale of about 10 questions that ask about different sort of dimensions of adverse experiences people can have. Did their parents get divorced? Did somebody in their household go to prison? Was there physical violence in their household? Was there sexual trauma in their childhood? All sorts of other things like this. Was a parent mentally ill? And the more questions people answer yes on that, the greater their likelihood is of dying of chronic medical diseases, including things like heart disease and other chronic conditions. But also, they have a much, much, much higher risk of addictions. They're much more likely to suffer from addiction. Other mental health diagnoses are far more common, and there's a greater severity. So we see that actually early childhood experiences really can affect everyone throughout their life. It's probably, I've heard people say that it's probably the biggest public health issue that we have. But really, some sort of trauma, whether it's big T trauma or little t trauma, is pretty ubiquitous. And trauma is an interesting thing because it depends on its effect, depends on our skills and our tools and how well we can cope with it. You can get a paper cut in a tropical environment, and if you've got some Neosporin to put on it, it's going to be fine. It's going to heal. If you don't have access to a Band-Aid or clean water or a paper cut, it's going to get infected. And that infection can spread throughout your hand. It can cause fevers. It can threaten your life. So it's not really the size of the trauma, but really how much our response to the trauma overwhelms our coping mechanisms. So what really happens with any sort of trauma is we have a shame reaction. We have something that wells up within us that says, I am not okay. I am not enough. And there have been other leaders in the field that talk a lot about shame. They've done a lot of work on shame. Brene Brown is one that most people are familiar with.
I'm sure we could spend a whole other episode on that alone, and
Sure.
I would love to have you back sometime for that. I want to go back to what I originally sort of opened up with about the TED Talk, and how isolation has fueled the opioid addiction. here we find ourselves again in a pandemic. How does isolation, further add fuel to the fire, if you will, with addiction?
Right.
Tell us more.
Yeah. So the part of the brain where the reward system is really nested is a circuit that involves the structure that I talk about in the TED Talk called the striatum. And the striatum has connections, has the expression of opioid receptors, and also is connected to other structures that are involved not only with physical pain, in terms of the emotional response to physical pain, right? The rage that you feel when you're in pain, the depression that you feel when you're in pain, the qualitative emotional discomfort of ouch, but it's also involved in social reward and social pain. So it's these same circuits between the prefrontal cortex and the medial anterior cingulate cortex and the striatum. Just jargon. Social reward circuits
Okay, there we go.
overlap
Something I can understand.
social reward circuits overlap with drug reward circuits is what it comes down to. And so what actually happens is when you don't have enough activity in those social reward circuits, like when you're isolated, you can actually cause conditions where the part of the brain that responds to drugs gets sensitized. So where you might ordinarily just get a response of a 5 to a drug, you're going to get a 10 or an 11 to a drug. So not only is something like a painkiller, you're going to have a stronger reaction to it, not necessarily on the level of your your respiration or your breathing or anything like that, but the degree to which it's going to cause relief is just going to be off the charts when you're in a system that is isolated or that is without this social reward. So we basically, with our culture and with a lot of circumstances, kind of sensitize these systems so people are able to get addicted more easily. I know you mentioned, that feeling of not being enough, that not belonging, like they didn't give me the manual, right? It is a ubiquitous narrative for any of us who have ever been bonded to a substance, to food, to anything like that. It seems to just be a very core part of it. And some of us who have genetic predispositions to things like alcoholism or addiction have certain genetic expressions that may actually make it harder to feel social reward. So we found that some of those same signals that are involved in social reward and addiction reward are these factors that are different in people with genetic predispositions to addiction. So it may be that they're surrounded by people who tell them that they love them, but they're not able to actually subjectively feel that sense of belongingness. But the first time they experience a drug that they become bonded to, they feel that belongingness. They feel it for the first time. And oftentimes they didn't even know what they were missing until
it makes a lot of sense. Yeah.
They experience it the first time. So that's sort of been our classic 1 to 2 out of 10 with addiction. But I think what's happened and what's accelerated during the COVID pandemic is that we have increasing numbers of people whose systems are getting sensitized, who are experiencing less social reward. And it's sort of like you can tune the system to be kind of like a person who maybe has a harder time feeling social reward to begin with. Those people and so you can think of it as a spiritual malady. You can think of it as a malady of disconnection from one another. And I think we're actually talking about much the same thing in terms of brain circuitry. So the question is, what are the ways that we can meet this need, that we can get this circuit back balanced? Because you can practice doing a behavior, you can practice doing a relapse prevention behavior when you feel a craving all you want. But if that craving is still there and is still going to be coming up for the rest of your life, then you're not free. You're not free from that addiction. There's a variety of psychological, spiritual treatments, technologies that we have that can get people free, but they're not all accessible to everybody. And not everybody, there's a lot of barriers to some people participating in some of those. And so one of the things that I've been looking at is, what if we got rid of this or minimize this shame and this isolation piece even earlier on? I'm not saying that people necessarily, that it's a magic bullet and people, are able to bond to other people instead of their substances, but it helps sort of push the system along so that when they access the resources, we've got a much, much better chance of actually changing and actually nudging the system into a healthy way of being.
Have you looked at that? So the ha- have you done research surrounding that and sort of combating that shame and guilt early on and seen some outcomes with that?
So we have seen some outcomes. So when I came into this, I got real interested when I got involved with Seek Healing and doing this research. So we set up a research study. What I realized when I first started working with Jennifer and wanted to ask this question was there was no experimental paradigm for this. There was no program where that was the intervention. And so the first thing we had to do was create an intervention, create a program that did that. And then we could study it. So right now what I'm doing is we have a fabulous program here in Asheville, North Carolina, and we are verging on expanding and being able to start Seek Healing communities in other cities throughout the country. And
Lovely place, Asheville. I visited there a few years ago with my daughter. It was
isn't
absolutely
it
breathtaking.
gorgeous?
Robust recovery community as well there.
Great recovery community. And just a really, there's a lot of, I think we decided to come here for the pilot program because I think there was an opportunity for kind of a more open-minded approach where we could kind of come into the recovery ecosystem here and try something new. And it's worked out really well. This has been a really wonderful community, but it's also a community that, you know, and as in the rest of Appalachia is, has a big problem with opioid overdoses. So we've really been able to make a difference here. And
What does that program look like? So a little bit more about your Seek Healing program there in Asheville. It's a residential system? Do you have community housing? How does that look?
it's not residential yet, although we do have a dream of having, ultimately having a model that can have a residential component to it. And it's not a treatment program. It's not a clinical treatment program. What it is it's a social health intervention. So we are part of a broader infrastructure of resources that people can access. But what we do is we provide opportunities for meaningful, deep, authentic connection between human beings and participation and experience of community. So we have connection practices where people can come, basically see and be seen. We've got, we do training for skills and being able to listen without judge and to listen and reflect without judgment, and to be able to be with somebody without trying to fix them, without trying to give them advice. So we have some methods for minimizing shame and minimizing hierarchy. So another thing that's different is we don't have people who are, you know, the treatment professionals and the people who are, you know, the patients. We really, everybody in the community is a seeker, myself included. And what a seeker is somebody who is seeking in the process of renegotiating their relationship with behavior or substances that don't serve. So we basically recognize that when it comes to emotional pain, it's all harm reduction. Whether we're using excessive amounts of caffeine or nicotine, whether we're using food, whether we're using other eating disordered behaviors, sex, gambling, or something like mood or mind altering chemical substances, we're all essentially engaging in the same process of analgesia, trying to feel okay and mitigate the experience of shame that we feel when we contemplate being with other people or the pain of not being with other people. And so we break that down so that it's not just people with a lived experience of addiction. I'd say probably 2/3 of the community has some experience in it.
Yeah.
About a third are in long-term recovery. Another third are early on in their healing journeys.
I gotta say, I love how you do that, and you bring everyone together in that sort of environment of care, if you will, and move out of perhaps the traditional. If it was a treatment center, you're an object rather than everyone's a recipient. Everyone's sort of in a recipient
Yeah,
role versus object.
it's
Um,
it's huge, right? I mean, anybody who's been in a treatment center, it's kind of, you know, it's the best that we've got and it saves lives, but there's also elements of it that can be really belittling and really, and it just something that you just kind of have to put up with to get what you need from it.
Yeah,
Uh,
my own episode of treatment was in 2009. One of the things I got out of it, Dr. Wurzman, was the fact that I didn't want to go through it again. I just on an intellectual level, I'm like, why would I ever want to do this again? And for some reason, knock on wood, because it's so far that's been my only episode of care. I sort of understood that and then, but I've known folks that have gone through 12, 15, 18 treatment episodes and centers, whatever you want to call it. And it takes what it takes. And I agree with you. The best that we got with what we're working with, it does save lives. However, your model is very interesting.
What happens is I think you develop a disease-based identity, but you also sort of, it's not that I don't actually have a problem with the disease model of addiction. I just think it's incomplete.
Okay.
I think it's really incomplete. I think that when we think of a disease as something that is only in an individual and only in an individual's brain, it's ignoring the fact that brains interact with their environment and minds interact with other minds. And those things actually, in turn, affect how the brain wires and rewires itself. So we need to be thinking, I believe, of the disease of addiction, so to speak, as a community level disease, as a disease of disconnection, as a disease of meaning, a disease of belongingness, a disease of shame and isolation, and just being out of balance, I think, with the way that human beings are supposed to be. Really what it is, addiction, I think, is a fundamental part of the human condition.
Yeah.
I really think it is. But in some of us, what happens is we have these experiences. And of course, our brains, the longer it's exposed to something like opioids or alcohol, actually does change.
So can I ask you a quick question about that? That
Uh-huh.
was a good point, and something I've been wanting to ask is, what certainly your TED talk was in that title in itself was focused on the opioid pandemic, different type of pandemic. Would you say that isolation fuels opioid use disorder any more than, alcohol or benzodiazepine or, cocaine use disorder? I mean, is it more pronounced in the opioid?
I don't think it does, but I think that opioids are a more effective, quote unquote, treatment for that condition.
Yeah.
So I think actually alcohol, I don't know what the statistics are of the incidence of opioid use disorders versus alcohol use disorders, but I wouldn't be surprised if alcohol use disorder incidence has risen more during the pandemic than opioids, because a lot of people who were social drinkers, moderate drinkers, maybe even heavy drinkers, have become more alcoholic pattern drinkers in isolation. They just talk about, the wheels just came off because they're home every day. They can be drinking every day. They can have their coffee mug with
they
vodka
deliver
and orange juice in it, but nobody can smell it because you're sitting there in a Zoom meeting, right? Who knows?
They're delivering alcohol in my county.
Oh, sure.
Now. So while they can't serve alcohol in restaurants, they're closed, and they're now delivering it. So,
and really, there are certain drugs that have different profiles. So alcohol, sugar, and opioids tend to activate some overlapping circuits. Really some opioid circuits. Things that are stimulants activate kind of a slightly different profile and engage slightly different circuits. But I think that really all of them, anything that people can get some relief and some escape from, but particularly alcohol and opioids and sugar, are the things that I think people have just lost control of their use in this time. And I think that is related to the isolation. We've had a wonderful natural experiment, which none of us would ever want to repeat, but of seeing what happens in a community. And there are some labs at Harvard, there are some other neuroimaging labs that I'd love to collaborate with my cohort at Keeling, who are actually measuring these things. So I was talking about this in 2017, but we actually have some real science that's been happening this year. And hopefully what can come out of that is an appreciation for how any sort of recovery can't just involve, connecting. I really believe it's not just about connecting with other so-called addicts. Really, I think it's connecting with humans. It's connecting with the broader humans. And what the treatment infrastructure doesn't do very well right now is allow people to reintegrate into that broader community. because there's still so much shame and stigma. And so what we've discovered as part of what Seek Healing is it's a participatory destigmatization model by everybody being able to relate in to some facet of addiction and recognize that we all have these behaviors. It decreases the shame, but it also minimizes the difference between, we're not talking about them versus us. We're seeing everybody from this perspective is an addict. It's just that some people have an additional experience where certain substances cause phenomenons of craving, for instance, or where after the first one, there is no stop. Other people are using it as self-medication. And sometimes it switches over. Sometimes that loss of control switches over, but I see it like a switch, like a dial, that we're dialing up and down. It's really a spectrum. When we can all be on that spectrum together, it decreases some of the shame. It's not I am an addict. It's like for instance, I do identify as an addict in a couple different ways. One of them is sugar. When I ingest sugar, something happens in my body and I get intense cravings and I cannot think of anything else but another bite and another bite. And I will do some crazy, insane things to get that drug. And it actually doesn't affect my body like it does everyone else's. I think there's a part of me, I could go into any room of Alcoholics Anonymous probably and hear stories and it would sound like my stories with sugar. Other people have reactions and it's yummy. And for me, there's fireworks going off in my soul on the first bite. I just happen to experience that with this one drug that affects me.
Yeah.
And maybe I have a mind that loses touch with the fact that I can't have that. I'm going to keep trying that experiment. That's my experience, right? And I don't need to label that. I think that people have that experience with Netflix.
Oh, it's all sorts. I mean,
right.
The social media, Netflix. Yeah. I when I first got into recovery, they sort of suggested to start eliminating the stuff in my life in the order that it's killing me. Right. So at that particular point, there's some really destructive substances. Then for me, became a tobacco and then, on and on. And I too struggle with the sugar thing like you're talking about.
Yeah, similar experience that I've had. And I just also happen to be a person who has the experience where really anything that gives me any sort of a buzz like that sort of like gets some engine going that wants other things in it. So for me, I've just felt like it's been important for me to have a particular pattern of non-use in my life that, sustains my being able to connect with other people, do my work, be a useful human in this world, be of service, be all these other things. And other people just need to abstain from the one thing that was really a problem for them.
Yeah.
And they don't have that same sort of generalized reaction. I think one thing that we do is we don't really prescribe other people's truth at Seek Healing. And this is a little bit radical. And we are not a replacement for other programs, but because there's so little judgment and little prescription, what we found is that in an environment of being able to express yourself, be received, not be given advice, and be accepted, people come around to what their own truth is. As a seeker, they find what their own truth is. And when something doesn't work, you could relate it to stages of change, like in recovery, but it's just a lot easier to recognize what's not serving you when you're not sitting there completely ashamed, belittled, feeling like, a piece of dirt, whatever. I don't know if I can curse on your podcast here, but it's so important to feel like you're a worthwhile human, even if you're still using a substance. And that is really the culture change that we're looking for. And when people can feel worthwhile when they're using a substance, it's amazing how people figure out what serves them and what doesn't. And maybe they need professional help to then get there, then get to that goal, or to then stay with that goal. They need other traditional resources, but having this level of support. In our pilot program, we had an 80 of people who were at risk of opioid overdoses. We had an 87% rate of people who were sticking to their use, non-use intentions at 6 months and a year out. That is unheard of.
Yeah, those
And
are really good stats. Yeah.
people who did return to use once or twice. The amazing thing in Seek Healing's program that I've noticed as the extra care program manager. So Seek Healing is a broader community program. And then we have additional services that we provide to people who are at risk of overdose. And we are looking at expanding that so that we can serve a broader population, people who have other mental health issues that put them at risk of suicide, or people who have things like alcohol use disorders or other things like that, as we grow and as our resources grow. And when people return to use, usually they fall off the map. They don't talk to their peer support. They don't talk to anybody. One of the things we find is they're still in contact with us at Seek Healing. They're still showing up, sometimes a little bit reluctantly, realizing that they can show up, but we don't lose touch. And we're able to be there with harm reduction support measures while they're getting their feet back underneath them, whether they go and decide to re-enter treatment or make some other change. And I think that really is saving lives in and of itself, because in a lot of traditional treatment things, when you return to use, you lose your housing, you lose your sober housing, and you can't get back into sober housing until you've had a free, a drug test that's clean. So basically you have to somehow stay sober while you're homeless for anywhere from, 4 days to a couple weeks. I don't know how people expect that to happen, right? Especially if there's not a bed for you at a detox because you're bonded to something like meth. So the community can really be, can really be a source of, I'd say, care, but not in a like you receive and I give. It's more with a model of sometimes I have resources and sometimes you have more resources, and we can mutually support each other.
That's wonderful. Well, there you have it, folks. I wanted to thank Dr. Rachel Wurzman for coming in today to teach us a little bit more about the neurological connection between isolation and addiction. We certainly need more Seek Healing social wellness programs coming up around the country, so we're looking forward to that. I want to remind everyone, if you have a loved one that needs help with addiction, please call Amethyst today at 855-80-SOBER, or visit us online at amethystrecoverycenters.com. To find more episodes of Share, visit amethystrecoverycenters.com/share, or subscribe wherever you get your podcasts. Dr. Wurzman, would you like to share your website as well?
Yeah, so you can find out more about our program at seekhealing.org, seekhealing.org. And we have online connection practices, so you don't have to be in the Asheville area to participate in the program. And we would love for as many people as would like to experience the magic of what we're doing. You can find out that information from the website.
Thanks so much, Doctor. And thanks for tuning in to another episode of Share. I'm Kabir Singh, and we'll see you next time.